it does result in carbon monoxide as one of the byproducts, which is interesting. And then you've got the different enzymes that go all the way to conjugation. This is a picture version, which you might see a couple of times during this slide. I'll only read it to you once, but it does help you really understand what bilirubin is, how it gets broken down, how it gets reabsorbed, etc. So senescent red cells, or basically old red cells like me, are a major source of heme proteins. They break down the bilirubin in the macrophages and in the reticular endothelial system. They are then unconjugated bilirubin is transported through the blood, complex to albumin, and then to the liver. The bilirubin is then taken up via facilitated diffusion by the liver and conjugated with glucuronic acid. The conjugated bilirubin is actively secreted into bile and then the intestine. In the intestine, glucuronic acid is removed by the bacteria and the resulting bilirubin is converted to urobilinogen down here. Some of the urobilinogen is reabsorbed from the gut and enters the portal blood up here. A portion of this urobilinogen is then in the enterohepatic urobilinogen cycle. The remainder of the urobilinogen is transported by the blood to the kidney, whereas again converted and excreted in the urine, giving the urine the characteristic yellow color. Urobilinogen is also oxidized in the intestinal bacteria to the brown color in the stool. So we see the yellow color in the urine and the brown color in the stool, all from the bilirubin breakdown. So again, you may see this pop up again, but it's a picture form that helps you really understand how bilirubin is transported and changed as it goes through your body. So physiologic versus pathologic. We have lots of names for bilirubin, and I'm not really sure why, but we all talked about all of them, and it's good to keep them straight. Indirect is unconjugated versus direct or the conjugated bilirubin. And we have different problems and different reasons to be concerned about each of these. Physiologic jaundice of the neonate. They have a high bilirubin load because they have a high hematocrit, which is broken down, so therefore you get more bilirubin. They're not great at that, so they have an inefficient process. Their red cells turn over faster than ours, so they even have more heme production, and they have the intrahepatic circulation going on, which they're absorbing more. Their hepatic bilirubin uptake is very variable, and they're not very efficient with their enzymes yet. Therefore, they don't conjugate it as well as we do. So they have more unconjugated bilirubin present. Again, same picture, I'm not going to read it to you again, just how it works. So, unconjugated hyperbilirubinemia. The 95th percentile at 4 days of age is 17. So that's the highest that you typically get on average at 4 days of age. The 3-day average varies with ethnicity. East Asians have a higher unconjugated bilirubin. Hispanics, not sure they quite number, but they're kind of in between, where African American and Caucasian are typically around 5.5. So all babies have problems with bilirubin. Some have it more than others, and some we can see it easier in than others. Unconjugated hyperbilirubinemia. One common reason we see it is in what's called breastfeeding jaundice. Breastfeeding jaundice is really somewhat of a failure of breastfeeding to go perfectly well. There may be a little caloric deprivation with the increase of free fatty acids, which affect the conjugation. So they might not be getting the calories they need. They again have the heightened intrahepatic circulation that I talked about already. They have some meconium plugging, so they're not stooling efficiently and therefore have more bilirubin backlog, and they're dehydrated. Those of you who've been with me in clinic have heard me talk about that you can melt a baby. Well, this baby down here is getting melted. The other, let's see, last block I think it was, I had a baby come into clinic and I was teasing the mom and grandmama about having 42 blankets on the baby. And come to find out, we had given them several of the blankets in the workup room, so that's why they had more on the baby. but dehydration does play a big role in jaundice of neonates. Breast milk jaundice, differently, there are several substances in breast milk that cause problems with the conjugation. So that's why breast milk jaundice occurs. And we'll talk about those both more in a few minutes. But breastfeeding, we want to encourage. In the old days, we ask people to stop if we notice jaundice, and now we rarely do, and we really want to encourage breastfeeding. So why do we have those, and what are the characteristics of breastfeeding versus breast milk jaundice? Breastfeeding is early on. As I said, it's more related to calories and hydration status. It's commonly occur peaks at 3 to 4 days of age when breastfeeding is just taking off. You can diagnose it clinically because the baby's not having enough wets. They should have 4 to 6 wet diapers a day. They should also have 3 to 4 at a minimum yellow-seated bowel movements a day. And also breastfeeding babies may have a greater than 10% loss of weight from their birth weight. They should breastfeed every 2 to 3 hours. They should be encouraged to do that. They need to feed 8 to 12 times a day. If they're having trouble with feeding, you might want to recommend formula supplementation so that they can stay hydrated. Again, previously we recommended water or glucose water, which has been shown to be ineffective in lowering the bilirubin and can also be dangerous because it affects the sodium metabolism or hyponatremia. So therefore, we don't recommend that anymore. We also can treat it with phototherapy, and we'll talk about that more in a few minutes. Breast milk jaundice is different, and again, it occurs later, related to the enzymes that are there, and it's more common at 6 to 14 days of age. Clinical diagnosis, again, if you really want to know what it is, you can withhold breastfeeding and it will drop, but we don't recommend doing that. We recommend feeding through it, and the treatment is typically none. It will go away on its own slowly. It can last up to like 8 to 12 weeks of slight yellow color. Hemolytic causes. Again, we talked about hyperbilirubinemia being related to heme breakdown. So why do newborns have more heme? In fetal hydrops, there's obviously more breakdown. ABO, or minor group incompatibilities, there's going to be more breakdown. RBC morphology variants are going to be more breakdown. Spherocytosis as an example of that. G6PD. This is something that we really need to think of, especially when you're seeing prolonged jaundice. It'll cause up to 30% of modern day kernicterus. So don't forget about this. It's sex-linked inheritance. We commonly see it in Black males. So do think about it and order the test if you're having prolonged jaundice. And don't miss it. Hemoglobinopathies, again, you're looking at your newborn screens to notice this. Unfortunately, we don't get them back till they're about 2 weeks of age, so your family history may be more helpful in thinking about this as a possibility or doing more specific tests looking for it if you're having significant jaundice. And infections can infect both unconjugated hyperbilirubinemia and conjugated hyperbilirubinemia, so that's something to be aware of and think about too. Usually those babies are going to be sicker and have more problems going on. Non-hemolytic causes, birth trauma. If they have a large caput or cephalohematoma, you've got significant bruising that needs to be broken down, so therefore you're going to have more heme products. If you've got IVH, again, there's more blood spilled, so more breakdown. Polycythemia, we already talked about the fact that they have a higher hematocrit than we do, so you're going to have more breakdown there too. And then you're going to run into problems with dehydration with pyloric stenosis and ileus, so therefore you're going to have more bilirubin problems in those kids as well. Decreased conjugation, also going to give you problems with hyperbilirubinemia. Prematurity, the whole system of bilirubin breakdown is immature with immature enzymes, so therefore prematurity is going to be a significant risk factor. Hypothyroidism is going to be a significant risk factor, so another thing that you're going to look for in your newborn screens, but again, they don't get back quickly, But when you're having prolonged problems with hyperbilirubinemia, that's something you need to think of. Gilbert's inherited autosomal recessively, and we know someone famous who has that, and that we work with. And Crigler-Najjar syndrome is another problem that can cause prolonged hyperbilirubinemia. Why do we worry about it? You know, I've been around a long time. This is something that we've talked about a long time. Again, originally bilirubin was discovered as a problem in around the 1740s, and they talked about the yellow color. In the 1800s, nurses noticed that the babies who were closest to the windows in the nursery had less of a problem. So we realized that the sunlight affected it, and it helped with the breakdown. And why are we worried about it? What does it do? Again, we worried about it a lot in the 1950s, and then we backed off, and now we're concerned about it and have more specific clinical practice guidelines. The AAP came out with a clinical practice guideline in 2004 to get everybody on the same page of how to deal with this. And they updated it in 2012. Those articles are in your Google Classroom that Dr. Lindsay sends out to you. So to get even more information about this, obviously read those. I read them a couple of times recently, obviously. So why are we worried about it? Kernicterus. Kernicterus, I've seen, the only case I've ever seen was in our clinic many years ago. It was one of our residents' continuity clinic patients that we had in our clinic. So that's the only time I've seen it, but it does occur. And we don't see it as much now because we're all treating it and being very aggressive following our algorithms. But it is a problem with unconjugated bilirubin collecting in the brain, primarily around the basal ganglia, the oculomotor nuclei, and the auditory nuclei. So you can see it there in the pictures. Kernicterus, why is it a problem? Well, it's one of the main causes of CP, and again, we used to see it a lot, and now decreased because everybody's listening to this and following the recommendations. But how does it present? These will be board questions for you because we are still concerned about it, although we don't see it that much anymore. It presents with lethargy, decreased feeding, hypotonia or hypertonia, a high-pitched cry, a torticollis, opsitonis, the setting sun sign with the eyes, fever, seizures, and even death. And then you have chronic problems with it too. And you can read those, but the kernicterus has been now named for mainly the chronic problems, and acute bilirubin encephalopathy are the more presenting signs that you need to worry about when you see them coming on. Obviously, some of these can be for other reasons too. So if you don't have a yellow baby, you need to think obviously about other problems causing these signs. Why do we have bilirubin at all? It's an excellent antioxidant. Caucasians will have different variants of the enzymes. So we'll have, some people will have a better problem with conjugated bilirubin than others. East Asians have different transporter variants, so they have higher numbers than we do. And biliverdin is a non-toxic byproduct. So that's why we have bilirubin. How do we treat it? Phototherapy, most commonly is what y'all are used to seeing. Exchange transfusions. Back in the day when I used to have to sit neonatal and push blood in, pull blood out all night long, we did more of those, which is a very, very risky and scary procedure with a lot of problems associated with it, and we don't have to do it much anymore, thank goodness. Phenobarbital, rarely used. Again, it does induce the enzymes of conjugation, so if you're really desperate and need help trying to get the bilirubin down, we still sometimes use it, but not as commonly as we did in the past when we saw more of this problem. Again, bilirubin broken down to photoisomers with light therapy. It's typically, since bilirubin is a yellow color, jaundice is a yellow color, the wavelength we use is the blue light therapy, and it's around the 460 wavelength variety. So that's why you see blue lights when you're seeing phototherapy happen, because it's the best absorbed and helps break down into water-soluble isomers. Conjugated hyperbilirubinemia. If this is greater than 2, this is always pathologic, or if it's 20% of the total bili. On the history and physical of these kids, you'll see a dark urine, you'll see acholic stools. Remember how we talked about how the breakdown products cause the color? So if it's not, or if there's too much conjugated, you're going to get acholic stools. Jaundice presents greater than 3 weeks, and this is going to be typically a later onset because of the way that bilirubin is broken down. Remember the picture that I showed you, and here how the conjugation enzymes. Another picture. I forgot that I put them there for you to see again. Conjugated hyperbilirubinemia. What do we need to worry about in these cases? Probably the biggest thing that you do not want to miss as a young doctor is biliary atresia. 45% of cases present with conjugated hyperbilirubinemia, and those are the cause of the most common reason that you'll have conjugated hyperbilirubinemia. And it's something that needs to be referred to a surgeon typically by 6 weeks of age. So you don't want to miss that because they need to get fixed as quickly as they can to have good long-term outcomes. Alagille is another problem with intrahepatic cholestasis because of the progressive loss of the bile ducts, and progressive familial intrahepatic cholestasis, or PFIC, is 25% of the cases. Severe alpha-1 antitrypsin deficiency is another cause, and there's a few other causes of conjugated hyperbilirubinemia too. That's the whole list of all of them that you probably can't read. I don't know how it shows up on your screen, but there's lots and lots of reasons to worry about it. Probably some of the more common ones are infections. I think ones that I've seen were torch infections in the past, yeah, and those were listed over on this side with CMV. The one that I actually saw last was a syphilis infection that gave conjugated hyperbilirubinemia. And those babies, instead of having the typical classic yellow color, sometimes are more of a greenish yellow, a little bit scarier looking color to them. But again, lots of things to think about. Don't forget about galactosemia, which are also going to come back on your newborn screens. Newborn screens are very, very important to keep a look at and make sure you find them and follow them. The history. Again, the 1950s to 1970s, we aggressively treated hyperbilirubinemia, and kernicterus was pretty much eradicated. And then you'll see in 1980 to 1990, which is the time when I was trained. I graduated med school in 82. I finished residency in 86 because of my transition from family practice to peds. So I was in the prime time when we were more laid back about it. And unfortunately, we did see kernicterus spiking. So that's why we've got very aggressive with the guidelines now. And RhoGAM being more commonly used prenatally for moms. And you've got the bilirubin management algorithm to follow, which we'll see in a few minutes. But that's in the clinical practice guidelines that are, again, as I said before, readily available for you on your Google Classroom. And you also have BiliTool, which makes you not even have to think much anymore. You just plug it in and do what it tells you to do. AAP guidelines, here we go. The baby's dressed in yellow. In the nursery where I was in private practice, the walls were painted yellow. So it always made it hard to figure out which babies were truly jaundiced. You'll notice that when I examine a baby, I'll push on their nose or push on their chest to be able to see the jaundice a little better, especially in African American babies where it's much harder to see. Okay, this is what you have, the algorithm for management of jaundice in the newborn nursery. It's very easy to follow, very self-explanatory. The main thing is that you need to think about it, you need to follow it, and get the labs when you're needed. And also, you may not have to do labs, but the transcutaneous bilirubin monitors have gotten much better. So they are more closely connected to the true total serum bili that you get from the lab as well. But anyway, it'll have this readily available. You probably do in newborn nursery, and you can follow it very closely and figure out when to check, how soon to repeat, etc. So, jaundice in the first 24 hours, jaundice appearing excessive for the infant's age, get the transcutaneous bili or total serum bili. And this is in a jaundice infant 35 weeks or more gestation who would be in the newborn nursery. We're not talking about preemies, that's a whole different category. If the infant is receiving phototherapy or the total serum bilirubin is rising rapidly, crossing percentiles and not explained, then you might want to get more tests. The blood type, the DAT or Coombs test, the complete blood count and smear. Remember looking at what the red cells look like. Measure their direct or conjugated bilirubin so you can subtract that from the total serum bilirubin. So you'll get a fractionated bilirubin because you really plan phototherapy based on what the unconjugated bilirubin is. You might gonna get a reticulocyte count. Remember we talked about G6PD being a big factor you may want to measure here as well. Carbon monoxide being a byproduct of bilirubin breakdown, you may want to measure that in respiratory wise. And repeat the total serum bilirubin often in 4 to 24 hours depending on their rate of rise. When their total serum bilirubin begins to approach exchange levels or not responding, then again, you need to think about those labs again, look for other reasons, evaluating for sepsis or other infections like we talked about earlier too. If the jaundice is present beyond 3 weeks of age or you have a sick infant, again, think of total and direct bilirubin. If the direct bilirubin is elevated, evaluate for problems of causes of cholestasis like we mentioned earlier. Again, newborn screens become very important. I've mentioned it several times. The thyroid galactosemia that I've already talked about, and other signs of hypothyroidism in the infant. We had a baby just recently in clinic who came in and we found an abnormality on their newborn screen, which had not been seen for quite some time because the baby didn't follow up as recommended. So we all need to do better at following our newborn screens and following our babies to make sure that they're not slipping through the cracks. That's why the state lab sends out letters to the doctors they think are going to take care of the baby. And if you're not taking care of that baby, you need to help the state lab find where that baby is so they can get help and not have a problem that gets prolonged. You're used to the nomograms with the risk zones, the high risk zone being higher than the 95th percentile, the high intermediate zone, the low intermediate risk zone, and the low risk zone. Again, these are in term or greater than 35-week babies. This is what we're talking about in these graphs. Your tiny nomogram, this is telling you how soon to repeat it. High risk, 4 to 8 hours. And the high intermediate, 8 to 12 hours. Low intermediate, within 48 hours. And low risk zone, 3 to 5 days. And depending on how low risk, whether you can just follow them clinically and not have to actually check a lab value. In Prisma Health newborn package, these are the things that get done. They also do the transcutaneous bilirubin, and again, thanks to the 2004 clinical practice guidelines, all babies now get screened so that it doesn't get missed, and all babies get followed appropriately. So that's a new change that doesn't seem new to you because it's been done ever since you've been around, but it is new to those of us who've been around a while. Hospitalized phototherapy threshold. Again, infants at lower risk, the dotted line, the dashed line, infants at medium risk, and infants at higher risk. The risk factors down there on the bottom for you. Again, hemolytic anemias from isoimmunization, G6PD, which I've talked about over and over and over again, asphyxia, acidosis, lethargy, we talked about that being a sign of kernicterus coming on, temp instability, sepsis, and low albumin. All signs of going to put you at more risk of needing phototherapy. Exchange transfusions thresholds, same kind of graphs, same kind of numbers, again, and same risk categories. So again, Billy Tool does this for you, gives you the graphs, but you have to, again, remember to look at the risk factors that are stratified out for you on Billy Tool. Don't just think everybody's a normal baby. In clinic, the questions that you need to ask when you're seeing a baby with jaundice in clinic are: how are they feeding? Breast versus formula. We talked about that some in the beginning. The amount and frequency. They should be feeding every 2 to 3 hours at a minimum. The stools, we talked about that already, 3 to 4 a day, CD and yellow, again at a minimum. Many breastfed babies will feed every time that they eat. And if they're feeding, 8 to 12 times a day, that's a lot of stools and a lot of diapers. Mason can probably tell you how many he's bought recently. The stool color, we mentioned that several times. Urine color and the frequency of urination. All those are important questions to ask when you're seeing a baby with jaundice in the clinic. And how rapid it came on, again, is going to point you more to more risk factors. And again, if they have these signs, which are telling you that the bilirubin is already becoming a very significant problem and needs to be handled quickly. So jaundice in breastfeeding infants. These slides were borrowed from Dr. Amaral. Okay, we've talked about it a little bit, but we'll reiterate it again because it's very important and has changed somewhat over time. Breastfed infants may have prolonged period of physiologic jaundice. The difficulties in established breastfeeding will increase it, like we talked about. Kind of starvation or failure of breastfeeding jaundice. I don't really want to call it failure, but not going so well. You don't want to use failure word in front of a mom. That'll make her not want to continue. So you do want to encourage the breastfeeding so that they get adequate caloric and nutrient intake, and to make everything pass and move on down. And again, like I've already said, supplemental water or glucose water does not lower the serum bilirubin and should not be given. Again, we did this in the past and we realized there were problems, so it is no longer recommended, and hopefully nobody's telling you to do that anymore. We also used to use glycerin suppositories to help them stool, and we don't do that anymore really either, at least in the outpatient setting. Breast milk jaundice, again, thanks to Dr. Amaral. This typically occurs in the first week, like we discussed. It's likely due to the factors in the breast milk, the beta-glucuronidase and the non-esterified fatty acids, which deconjugate the bilirubin in the intestines and increasing its ability to be absorbed rather than excreted. And you get the intrahepatic circulation of bilirubin, making the conjugated bilirubins be higher. This will peak 2 to 3 weeks of age and decrease slowly, like we talked about, some lasting as long as 12 weeks. I think my cute little granddaughter was very yellow until around 8 weeks or 10 weeks, so had to sit back and watch. Again, like we've already talked about. But again, as long as the baby is well, growing, thriving, continue breastfeeding. Can't stress that enough. Clinic. Look for the signs of dehydration on your exam. Look for hepatosplenomegaly. Look for ascites. Look for the dysmorphic features like the triangular facies of Alagilles, along with the other things of Alagilles. Macroglossia of hypothyroidism. Microcephaly, CMV, and other torch infections, and an odorous dark urine, which is also kind of telling you dehydration. Testing, what do we do? Over and over again, I've talked about newborn screens. Unfortunately, as I've said, they're not back initially. Our state takes 10 days to 2 weeks, but you can always call and check and see if they have it, or at least check the computer nowadays. Get the fractionated Billy, follow the nomograms, look at Billy tool, do what it says for you to do. Tier 2 levels, you get the CBC with the diff and the smear. Look at retic count, look at albumin, because that's what binds bilirubin. Look at the DAT test. Tier 3, again, the G6PD, the end-tidal volume of carbon monoxide, urine reducing substance. Ill appearing, think about infections. Admission criteria, this is going to vary with numbers, how good your follow-up is going to be. We might be more aggressive about admitting somebody on a Friday who we're not sure that they can get back to the lab for a repeat bilirubin. They may not have transportation. They may not have a mother who understands. They may have language problems. All of that may affect whether you're going to admit that day or recheck it the next morning. We had this problem over Labor Day with how we were going to get them checked, who was going to follow them up. So again, everything may affect whether you're going to admit for bilirubin therapy. Obviously, if it's the 95th percentile, you're going to initiate phototherapy, or if it's greater than 25 in a well-appearing infant, you're going to admit for phototherapy as well. Again, your risk factors. We've talked about these already, but there they are in a nice graph for you to think about. The major risk factors, the minor risk factors, and decreased risk. Obviously, the more term and older your baby is, the less of a problem it is. But they do need to think about it again. We've talked about all those, I think, already. Treatment. Again, you have seen the babies put in the bassinets, open bassinets, which are better than the overhead warmers. The blue lights, they measure the distance in between so they don't burn the baby or get them, not burn, but get them overheated, and protect their eyes. Typically, they can leave their diaper on because enough of their skin is exposed, but in a really elevated bilirubin, you may do more than one light and take the diaper off so you're getting more skin exposure. You may also do the Billy blanket at home, where you can set up and monitor their bilirubins at home. And they also have the Billy bed, which you kind of strap them down to a little light therapy and a little suit. So if you haven't seen those, you may want to look at them so you know what you're actually prescribing and sending them home. Most of the time, you can interrupt these phototherapy so that you can feed them and continue to get the hydration going. But if it's really high, then you may not even be able to continue breastfeeding because you don't want to interrupt the phototherapy, or you'll point the phototherapy at the mom and the baby to get it going. And these are just some average numbers for you to think about of when you need to possibly do exchange transfusions and phototherapy at their different ages. And remember, it's also affected by their gestational age as well. Here you go. Again, the same graph. Look at it over and over and over again. I know y'all all pull it up and look at it all the time. More guidelines for phototherapy. And again, these are term babies. It's greatly affected by the gestational age and other problems they may have. The algorithm, again, is in pediatrics. It came out in 2004. This is where you can find it. It's probably hanging up in your newborn nursery. Hopefully it's in your little quick checkbooks that you look at all the time as well. So you can follow it, and we can prevent this from becoming a problem like it was back when I was a resident. Many things have changed, and bilirubin is one of the many. This is where I escaped to. This is where I was this past weekend. It's a great place. Relax. There's no yellow in this picture. Questions? I don't know if I can see where they come, but if you have them, I'll be glad to try to answer them. Or you can run down the hall. I don't see any questions coming in, no chats coming in. Yeah, thanks. Y'all have a good morning.